the ligaments. And so on the left here, I'm going to do just the major ligaments that would be responsible for the atlantoaxial articulation. I know Francesca went in further and did the craniocervical or the occipito-atlantal. And on the left side, we've got the tectorial membrane, which then becomes the posterior longitudinal ligament. Extremely important structure because it attaches all the way from the skull, and then as it becomes the PLL, goes all the way down to the tailbone. Its job, obviously, preventing anterior translation of the vertebrae. Very important structure in stabilizing the skull onto C1. And when you peel that away, so where the green dot is, if you peel that away, you get to see what's behind it. And so the red cross in the middle, that is the cruciate ligaments. That's the transverse. It's got a cephalite and a caudal band to it, and it's got two transverse bands to it. On either side of those transverse bands, you have the accessory atlantoaxial ligament, or the spinal accessory ligament, as it's called. And then the two diagonal ones right up in here, going from the dens up to the occipital condyles, those are the alar ligaments. And so the alar ligaments and the spinal accessory or accessory atlantoaxial ligaments, they together prevent lateral translation of C1 on C2. So generally, when you have visible lateral translation, you will suspect injury to both of those. However, the accessory ligaments are extremely difficult to visualize on MR compared to the alars, especially if the coronal sequencing is done properly and with the thin enough slicing, generally on a T2 weighted MRI. I want to just go tie into something that was asked of Francesca. When you have, let's call these the left alar and accessory ligaments, when those are damaged, you're going to actually have right translation excess and vice versa. So it's actually the opposite alar and accessory ligament compared to the side of translation. So when you have left-sided damage, you'll have excessive right-sided translation and vice versa. And when you have both left and right, it'll be much more severe translation, generally to both sides on the open mouth lateral tilt imaging. And then we have on either side of that, so we have the capsular joints between C1 and C2 here, and then between C0 and C1. And like Francesca was saying, when you're dealing with regenerative medicine, whether it's prolotherapy, platelet-rich plasma, or stem cells, when they're trying to get into this articulation here, which is generally as best that they can do, is to get into the C1, C2 capsular ligaments to inject them, they have to be really careful of where the vertebral artery sits. Sometimes it's tortuous, sometimes it's actually really close to the capsule. So in order to avoid injecting that and giving a person potentially a stroke, fluoroscopy guidance and or ultrasound guidance is the preferred method, and there's only a select handful of people that do prolotherapy that are equipped to do that and are experienced and willing to do it. So when people tell you that they've had prolotherapy in their entire neck and it hasn't really helped, or it's given them a minor amount of help, you can almost always assume that whoever did it, whether it's a physiatrist, anesthesiologist, whoever's done it, has not gone above C2, C3. If they go up to C1, C2, they would have done it under imaging guidance, and they would be somebody who's very experienced in that.